Dr. Robinson is a fantastic oncologist with a focus on breast cancer, and has won many awards for her
Mhm.
excellent patient care.
I find this a really difficult session because I don't see the audience. And I really do find it hard to know how things are going. But I will talk through this. And so the idea here is breast cancer for the boards, but also, and beyond. I try to give a little update about what's new in 2026. And also just give you general information beyond what you might need with the boards. But that's the focus. I've been practicing for 30 years. I teach at Harborview. I teach the fellows in the Hemont Clinic there, as I've been practicing at Virginia Mason, as I said. So, going through, I like to do this as just walk through a case study and change it as we go. And many of us have the experience of being contacted by family members. Breast cancer is a really common disease. And so we'll say, okay, your long day in the wards, and you find out that Aunt Susie has just felt a breast lump. What should she do? Now, obviously, this could be somebody walking into your clinic office. So, what is the evaluation of a new breast mass? Physical exam focused on breast exam and lymph nodes, axillary, supraclavicular, mammogram, ultrasound. And one of the really important things is, having a relationship with radiology. They can help guide you as to what the best step is. And one of the key points that always comes up is even if the imaging is negative, to pursue a biopsy in any case. There are various things that do not come up on mammogram and ultrasound. Classically, lobular carcinoma can have a diffuse presentation. And sometimes we need to add an MRI, and that's back to the having a relationship with your radiologist. Okay, so you get a call back. The biopsy came back, and she does have breast cancer. Is she going to be okay? So, what are the things one needs to know to answer that question? So you want to know a few things. One, you want to know what is the characteristics of the tumor itself. So you want to know stage. You want to know characteristics of the tumor. So stage is where is it? Um, Grade is what is it like? What's its personality? Patients get stage and grade mixed up all the time. And then you want to know about the receptors. So, general staging. Stage 0 is non-invasive breast cancer, classically ductal carcinoma in situ or the equivalent. It can be 10 centimeters, it can be 1 centimeter, it can be zero point 0.1 centimeters, and it's all stage 0 as long as it's non-invasive. So it's defined by biology and not size. Stage 1 breast cancer is 2 centimeters or less. I should fix that in my slide. Uh, and stage 2 is greater than 2 to 5 centimeters, or a small cancer with a small amount of lymph node involvement. And stage 3, larger cancer, more node involvement. And stage 4 is distant metastases. So, okay, everything comes down to the tissue. Um, if you don't have pathology you can rely upon, that is a huge problem. Any case we see in our hospital, we review all the pathology before we make treatment recommendations. That is the most important thing. Otherwise, you'll make errors. Okay, so what do you see? You may find on a pathology report, it might be completely benign. You may have atypical hyperplasia, and in primary care, this is an opportunity for primary prevention with tamoxifen and rarely aromatase inhibitors. You may find invasive versus non-invasive disease. Histology would be classically ductal carcinoma is the most common, lobular second most common. There's some specific favorable histologies, tubular mucinous, and some adverse histologies such as metaplastic. Grade I mentioned, that would be 1, 2, or 3. Stage is in Roman numerals, grade is in Arabic numerals. And then there's key receptors we look at, the estrogen receptor, the progesterone receptor, and HER2/neu. And in DCIS, we only report out ER or and not the other two. Okay, so grade 1, lowest risk. Grade 2, average risk. Grade 3, highest risk. But what one needs to know is certain biological types are grade 3, but they predict for better response to systemic agents. So a low-grade cancer, most of the cancer cells are dormant at a given time and they don't respond very well to chemotherapy. And they tend to be the ones that, if they're going to recur, will recur 7 to 10 to 15 years out, whereas a grade 3 tumor may recur 2 to 3 years out. So, very different condition and different implications. Most cancers are grade 2. Okay, so DCIS. So we're going to say that's what has been found. And she says, okay, the report says I have ductal carcinoma. Oh no, there's some other words I don't know. And it's actually very important. People see the carcinoma word and they don't understand what the in situ part means. And it's important to point that out. So how should we think about DCIS? What are the questions we want to know? So here's a MKSAP question that we can review and do the poll for that. So this is a 54-year-old woman, abnormal screening mammogram, new calcifications in multiple areas of the right breast. Biopsy shows ER positive DCIS with high nuclear grade. Bilateral mastectomy is chosen with right sentinel node biopsy. And pathology shows multiple areas in the right breast. The sentinel lymph nodes are negative. The left breast pathology was negative. You see the patient postoperatively. They're healing. They have tissue expanders in anticipation of reconstruction. And so, what is the next thing that one would recommend for this patient? Mhm. And somehow I lost the poll. There we go. Thank you. Okay, so here the right answer is no additional treatment, as most of you got. And the reason for that is the role of endocrine therapy and DCIS is secondary prevention. So the patient now has no significant residual breast tissue. There is always breast tissue left after bilateral mastectomy, in fact. So it's not 100% guarantee that you won't have a second event. There's a 1 to 3% risk of a second malignancy in the future. Endocrine therapy for DCIS cuts your risk of second malignancy in half. But if your risk is only, 1, 2, or 3%, cutting that in half is such a minimal amount that no additional treatment is recommended in this setting. Okay, I need to advance my slide. Okay. Great. So DCIS usually found on screening mammogram, not generally associated with a mass. One of the things we always say to our patients, which a patient said to me once, is it's called stage 0 because 0 people die of it. So there's a 100% survival rate. I think of it more like a precancer. You can have local recurrence. You can have a second primary later, and half the time that'll be invasive, half non-invasive. But per se, the survival rate is 100%. It can be ER positive or ER negative. There are 3 grades, which really predicts for what are the odds it would have become invasive in a meaningful, like sooner rather than later, 2 years more than 10. And again, the endocrine therapy is if there is residual breast tissue and only if the original DCIS was estrogen receptor positive. Okay, so we're going to change the story. There's a second opinion. A new pathologist says, wait a minute, it was invasive cancer. It is not DCIS. And so the question is, what is going to happen next for this patient? Is there ongoing, here, let me just answer the question. Is there ongoing monitoring after the first case? Yes, it would be a chest wall exam on an annual basis. And that's all a patient would need because there's no imaging that would be relevant. And after the patient has reconstruction, usually the reconstruction is anterior to the breast tissue. So often the exam is focused on the sides and around the edges. And one of the things, which I'm really not going to address too much today, is future HRT. which is definitely a big issue for these patients. And in this setting, it's shared decision making, but there's sort of uh, more of a movement to offer HRT, particularly and very definitely safe to give vaginal estrogen. Okay, so we said, what are the doctors going to do next? Hmm. Okay, so here's our next question. This is a staging question. The 52-year-old woman is evaluated in the office who has a left breast mass developed 3 months ago, otherwise no symptoms, perfectly healthy. The mass is 1.8 centimeters, upper outer quadrant of the left breast, no palpable lymphadenopathy, and imaging confirms this. And on core needle biopsy, it's a grade 3 tumor, and it's estrogen receptor negative, progesterone receptor negative, HER2 negative. And the question is, what is the appropriate staging imaging in this situation? Uh, Chest X-ray and bone scan, CT chest, abdomen, pelvis, CT chest, abdomen, pelvis, and brain MRI, or no imaging. Okay, so it looks like the group is focused on doing imaging. And the answer here is actually no imaging because this is a stage 1 cancer. And so we do not do systemic imaging in that situation. Systemic imaging is reserved. Um, for the boards, we'll say stage 3 or stage 4 patients. Um, in practice, if a patient has a triple negative tumor with high risk features and positive nodes, but is still only a stage 2, sometimes we will do staging. And that is specifically in asymptomatic patients. In symptomatic patients, we always image the areas that are symptomatic. So typically, it will be a CT chest, abdomen, pelvis with IV contrast along with a bone scan. Or nowadays, we often just do a PET CT to cover both of those, and brain MRI in high risk HER2 positive or triple negative breast cancers. But the board answer for stage 1 and stage 2, so up to a 5 centimeter tumor, is no systemic staging. Okay, so we're going to step back, and I just want to oh, hold on, let me see what the question is. Um, Okay, so for this patient, yes, patient would have surgery, followed by if it was a partial mastectomy, be followed by radiation. Um, and if they had a mastectomy, there'd be no radiation. And actually, if it's a triple negative tumor, they'd be offered adjuvant chemotherapy as well. Okay, so we're going to talk about the 3 categories of breast cancer, and I'll go into that part more. The hormone receptor positive, the HER2 positive, and those can be estrogen receptor positive or negative, and then the triple negative breast cancers. Okay, so here we have an ER positive breast cancer question. 58-year-old postmenopausal patient undergoes follow-up evaluation for recently diagnosed breast cancer. They had their lumpectomy and sentinel node biopsy. And in this case, it was a 2.3 centimeter estrogen receptor positive, HER2 negative, grade 2 breast cancer. This would be probably the most common thing somebody would see. And the sentinel lymph nodes were negative. So this is a stage 2A because it's over 2 centimeters. Radiation is planned to complete breast conservation. And so what would be the next step to plan the patient's systemic therapy for this ER positive breast cancer? Okay, so there's a range here. So historically, um, in the 70s, patients would all get chemotherapy. That evolved to being endocrine therapy and chemotherapy in high-risk cases. And then what's happened since then is that we now have tests, the multi-gene recurrence assay, that helps us predict whether chemotherapy will be of value for patients. So back to what I told you guys earlier about grade, the higher the grade, the more likely a patient's cancer will benefit from chemotherapy because more of the cells are active, or as we say to patients, awake and eating. Whereas the grade 1 tumors will say is more like the cancer is asleep on the couch and would sleep through the chemotherapy. So we use these multi-gene recurrence assays to decide who would benefit from chemotherapy. And I think of it as a fancy grade. Different companies make different tests where they assess different proliferation genes, but that's kind of the idea. And obviously, we want to avoid chemotherapy in the patients who won't benefit it and give it to the patients who do benefit it. And let me just get to the next. So, as I said, this is the most common form of breast cancer. In this cancer, we almost always do surgery first, unless it's a really advanced stage disease and we need to debulk to do surgery. So surgery, then chemotherapy is going to be given, then radiation if the patient's had breast conservation, and then endocrine therapy would follow. As I said, if it's higher stage and we want to debulk, um, that's what we would do. So the genomic testing, so to make clear, genetic testing is testing the patient for what they were born with. Genomic testing is testing the tumor itself, the genome of the tumor, and otherwise known as a multi-gene recurrence assay. We will not send this on a 80-year-old with dementia. There's no point. We're not going to offer them chemotherapy. And just like anything, you don't want to order tests if you're not going to use the results. So this is done for patients who have node negative breast cancer and up to 4 positive nodes. After that, we'll generally give chemotherapy. Um, and so the two main brands, one's called MammaPrint, and the one we use most often is called Oncotype DX. These are covered by insurance. If you had to pay for it, it'd be about $7,000 a test. But obviously, avoiding chemotherapy is ideal if we can do it and picking out who needs it. So it's a really wonderful advance we've been using over the past 15, 20 years. So in estrogen receptor positive breast cancer, late relapse is more common than early relapse. Patients will see it 5 years and say, "Yay, I'm 5 years out." And unfortunately, I usually have told them this in advance, that their risk of recurrence is just as high year 5 to 10, if not higher, than year 0 to 5. And the time frame is often year 5 to 15 for these cancers in terms of watching for distant metastatic disease spread. Okay, so as I said, when we use the genomic testing, it's looking at the biology of the cancer, not the size and the extent, but we do use the extent in the sense that if patient has 4 or more lymph nodes, we give them chemotherapy. Okay, next question. Endocrine therapy is a pretty common topic for breast cancer questions because patients are on these for years and are most often, often seen by their primary care. 62-year-old is evaluated in the office. Were diagnosed with atypical ductal hyperplasia. They had a right total hip replacement 2 years ago that was complicated by a DVT. Otherwise, the patient is healthy. They have a well-healed breast incision, no other findings. And so we mentioned earlier the idea of chemo prevention. So what would be the best breast cancer chemo prevention for this particular patient? All right, so the answers are across the board. To point out, the key thing in this story was the fact that the patient had a DVT, and we'll talk about this. but tamoxifen and raloxifene are in the same family, and they're both estrogen derivatives and have a risk of VTE, venous thromboembolic disease. So they would be avoided, even though tamoxifen is more often used these days for chemo prevention because we have a low dose option. So in this case, and aspirin, there was one old nurses study that talked about aspirin, but it's not indicated for breast cancer prevention and really hasn't panned out. So in this case, it would be exemestane, which is an aromatase inhibitor. And we're going to talk about these drugs coming up. Okay, so endocrine therapy, there are four ways we manipulate. Hold on, let me see the question. Um, that's a great question. So the question is, um, even if the DVT was provoked, you would still avoid a SERM. So I think that's a really good question because typically people who have clots related to birth control pills or pregnancy, those would be ones where you'd particularly say, hey, I would like to avoid a SERM. And I think if this was going to be if it was your only option. So this is a patient who has ADH, so they don't even have breast cancer. So you really want to avoid any side effects if something is simply to reduce incidence of breast cancer or not improve survival. So given that we have an alternative of the aromatase inhibitor, in this case, I would pick that. But you're right. I mean, you could argue, hey, it was a provoked DVT, um, and you could therefore give the SERM. I think you could make an argument if you didn't have an alternative. And I think the other problem, just from a multiple choice testing question thing, is that they gave you two SERMs. And so both of them are effective, though tamoxifen is more effective. So um, I think that's why you'd pick the aromatase inhibitor in this case, just from a, gaming the question standpoint. But I think if you didn't have aromatase inhibitors and you knew it was provoked, then yeah, I think you could talk to the patient and consider offering it. Um, okay, so let me go back. Okay, so you have SERMs. What does that mean? Selective estrogen receptor modulators. So tamoxifen and raloxifene, which is barely used, they are, if you will, they're estrogen agonists and antagonists, depending on where they go. So to breast cells, these drugs are anti-estrogen, if you will, fake estrogen, and yet to bones and uterus and your blood clotting system, they act like estrogen. So their activity depends on where they land. And we'll talk about that next slide. We have aromatase inhibitors, removing people's ovaries and suppressing ovaries with LHRH inhibitors is another form of endocrine therapy. And the newer kids on the block that historically have only been for metastatic disease are estrogen receptor downregulators, historically IM and then oral, and I'll walk you through these. Okay, so some tamoxifen been available since 1977. It was the very first targeted personalized cancer drug that ever existed and is still used and beneficial. Raloxifene, as I mentioned earlier, is in the same family, but is only used for bone density treatment or for breast cancer prevention and is not as good as tamoxifen in breast cancer prevention. These drugs are used both for premenopausal women and postmenopausal women. And because they act like estrogen away from breast tissue, the risks are VTE. And uterine cancer is a risk, less with raloxifene, which is why it was developed. But that uterine cancer risk is only if the patient is no longer menstruating. So a young woman does not have a uterine cancer risk. Historically, we said patients up to age 50 don't have that risk. Often these drugs reduce the severity of menses and the frequency of menses, but even if a patient has a menstrual period once or twice a year, to slough out the lining, it's enough to prevent the uterine polyps, uterine cancer. A positive is they increase bone density. And so if you have a patient who's had a hysterectomy and has osteoporosis, these are nice drug options. when you order the drug and you have a patient on an SSRI, you'll often get a pop-up that says, hey, um, the SSRIs will block the effectiveness of tamoxifen. This is a theoretical issue, and in practice, in large studies, is not in fact a problem. So the issue is that tamoxifen has to become endoxifen to be effective, and it turns out that it was thought the SSRIs keep that from happening, but it's only in one particular pathway, is CYP2 D6. But in real life, with real patients where you collect drug information, concomitant drugs, there is no decrease in effectiveness, but this is an ongoing conversation I'm always having with primary care docs and with pharmacies about this issue. And it's unfortunate that um, it still comes up because it's not in real life. Okay, so one of the really cool things for our high patients who are taking this for primary prevention, so people who've had DCIS or atypical ductal hyperplasia, is we have the option of baby tam instead of like baby aspirin. It's baby tam, which is 5 milligrams a day. They only come in 10, so you cut them in half, and for only 3 years. And the reason this was developed was because very few people take these medications for primary prevention. And researchers in Italy who did this study were trying to show that a lower dose for a shorter period of time is equally effective, which they did demonstrate, and has fewer risk of serious side effects. Some patients still are symptomatic from menopausal symptoms, but they have not seen the uterine cancer, decrease in polyps, and much lower risk of VTE. It's a really nice option for patients. Aromatase inhibitors have been around now 25 plus years, three different brands from three different companies. What they do is they decrease estrogen production in adrenal glands and adipose tissues. They do not stop estrogen production from ovaries, so it is only effective for women who are on ovarian suppression or if they're menopausal. These currently are a first line agent. Um, I will talk in a minute about a new oral agent that's a SERD that's more effective, but that hasn't been approved by the FDA yet. There isn't, because this is not an estrogen analog, there's no risk of DVT, no uterine cancer risk. They don't have the drug interactions. Unfortunately, by lowering estrogen levels, they can increase bone loss. So we usually do a baseline DEXA scan as we make these decisions, and we consider adding oral bisphosphonates. And as a separate point, IV bisphosphonates, such as zoledronic acid twice a year for 3 years, actually improves breast cancer survival rates in certain patient populations. Just interesting. It has to do with changing the bone structure so breast cancer cells can't hide there. And so often we're putting patients on bisphosphonates in any case. And these are an option for primary prevention, like the case we had. But when you can use a quarter dose drug for 3 years, the tamoxifen has become a lot more popular, and whereas this is a 5-year drug at full dose, but definitely still an option. Okay, so the selective estrogen receptor downregulators that I mentioned earlier, the SERDs, what they do is they bind to the estrogen receptor and essentially degrade it so there is no receptor. Um, and it turns out people on the aromatase inhibitors for long term, they end up becoming resistant to the aromatase inhibitors and develop this mutation called an estrogen receptor 1 or ESR1 mutation. And so the AIs no longer work for those patients, and these drugs can still work because they degrade the physically mutated structure itself. And so they're a really interesting new class of drug and don't have some of the same side effects, the menopausal side effects as the other ones. So starting in 2002, we had fulvestrant, which is 2 IM shots in the buttock that we give monthly. Um, it is otherwise well tolerated. Yes, we joke with patients that the one problem with the drug is it's a pain in the ass, because otherwise it is tolerable. Patients have to come into clinic to get it though, and it's a problem. But it's an excellent drug for metastatic breast cancer. And so for years, we've tried to develop oral versions of this. And starting in 2023, we now have an oral SERDs. They're crazy expensive. And this is a problem, $45,000 a year. Aromatase inhibitor might cost $100 a year and usually easily covered. And so the first oral SERDs that have been approved were for metastatic breast cancer, and you have to have demonstrated that ESR1 mutation, which can be done on testing of the blood or of the tumor that the patient last had biopsied. And ESR1 mutations can come and go based on selective pressure. So the interesting new drug is called giredestrant, and in December, it was shown that it is 30% more effective than aromatase inhibitors to use adjuvantly. But because of the crazy cost, it hasn't yet been approved yet. And I think they know it's valuable for all patients in an adjuvant setting and has fewer side effects, but the cost is going to be nuts. So it has not yet been approved. And it is as that much better than aromatase inhibitors, than aromatase inhibitor better than tamoxifen. So we're going to have to figure out how to make that work. Typical side effects in general of endocrine therapies, and this will come up in primary care, menopausal side effects. So vaginal dryness, UTIs from the dryness, uh, painful intercourse, decreased libido, insomnia, night sweats, hot flashes. Tamoxifen specifically can also give a vaginal discharge and Charlie horse type leg cramps. AIs can give you arthralgias, carpal tunnel syndrome, trigger finger, as though estrogen is a joint and um, tendon lubricant. The SERDs have less bone loss, less arthralgias. You can see elevated transaminases, some GI symptoms, rare bradycardia, so you have to monitor them differently. Weight gain is a big problem with these drugs. It is similar in magnitude to menopausal weight gain. Um, and this is going to come up at the end, but it's actually a big problem if you have women who may be cured and instead you're giving them diseases of obesity, cardiovascular issues. And so you have to be really careful and figure out how much are we really helping patients. And so I'll have a slide later on GLP-1s because that feeds into this a little bit. No pun intended. Okay, and so one of the big things that is really important over the last couple of years is vaginal estrogen is safe. And we are prescribing it for more and more patients. As you know, menopausal treatments are having a moment culturally. And in particular, vaginal estrogen is safe and can be given as a string every 3 months, or tablets that are inserted with applicators multiple times a week, or cream that can be applied with a finger or with applicators, and definitely now supported in breast cancer patients. Okay, so that was estrogen receptor positive breast cancer. I'm going to switch to the second category, which is triple negative, which we talked about briefly from one of the cases. It is the most aggressive. It's very responsive to systemic therapy, high risk of early relapse, high risk of brain metastases. We usually shrink the cancer and then operate. And now we use immunotherapy with our chemotherapy drugs to take the brakes off the immune system to allow your immune system to help fight the cancer. These are long, complex regimens with 5 drugs. And then patients go to surgery, and then there's a dividing point. If there's no cancer left at surgery, then the patients just continue their immune therapy to complete a whole year. And if there is cancer left at surgery, we add an oral chemotherapy drug for 6 months. So this allows us to determine if you give it pre-op, it's a way to test within the patient whether the drugs you're using are effective. Third type of cancer is the HER2 positive breast cancer. So these are receptors on the cell that pair up and stick out of the cell. I tell patients kind of looks like the picture of the COVID virus that they may have seen with the spikes, not quite, but gives them an idea. And these are highly curable regardless of stage. They can also have estrogen receptors or not. They have the earliest relapses, especially when they're estrogen negative, highest risk of brain mets. And we give patients a combination of chemotherapy and antibodies that have been engineered to attach to the outside part of the HER2 protein as it sticks outside the cell. And that also helps your immune system see the cancer better. So we give pre-op treatment, typically for about 18 weeks, and then patients go to surgery, and then they eventually have the radiation. And again, here, whether there's cancer left at surgery or not allows us to decide, should we keep the treatment of just antibodies post-op, or should we add a stronger drug, which is often an antibody drug conjugate, so basically chemotherapy attached to the antibody. So usually they get a year of treatment, and then they go on, if they're estrogen positive, to their 5 years of endocrine therapy. So those are the three big buckets of breast cancer. Okay, so I'm going to just quickly cover some other topics that tend to come up in the questions. Okay, so inflammatory breast cancer tends to always come up. 50-year-old is evaluated for heaviness and swelling in the right breast at 3 weeks duration. She noticed 1 week ago that the outer breast was pink. Otherwise, patient is healthy. There is no mass in the breast. There is no tenderness. The CBC is normal. What is the most likely diagnosis? So in this case, it is inflammatory breast cancer, which is in the title of my question. I always think this would be a better question to throw in not by a breast cancer doctor. So the reason it is most likely is because there's a normal CBC and age of the patient and so on. But the main thing is, I will tell you that vast majority of patients I see with this condition have already been given a course of antibiotics. So it is definitely often thought to be infection until proven otherwise. So, I mean, it doesn't harm anything to do that. It's, I suppose, a short delay, but that's not what the patient has. They have inflammatory breast cancer. Okay. So, next question. So, we have a patient, a 56-year-old woman, evaluated for finding suspicious for inflammatory breast cancer. On exam, normal vital signs, the right breast is enlarged, like the picture we just saw. Skin is thickened, erythematous. Often it looks like it has what we call a peau d'orange or skin of an orange appearance, where you see the pores. The mass is this one does have a mass, 5 by 4 centimeters in the lower outer breast. And I guess to explain what this is the lymphatic channels are blocked, and that's what causes this inflammatory appearance. So in this case, there's a palpably enlarged right axial lymph node. On biopsy, it is a triple negative, ER/PR and HER2 negative invasive ductal carcinoma. The scans are negative for metastatic disease. And so, what would be the order of treatment for a patient like this? Um, yep. So basically, it's C for which is that you shrink it first, and then the key point here is inflammatory patients always have mastectomy. Um, and part of this is because you know it's in the lymphatics throughout the breast. And so so breast conservation is not an option. I wonder if that will change in the future as our systemic therapies continue to improve, but that is the correct answer. But then everybody also gets radiation. Um, and if it is triple negative, the patient would have also had preoperative pembrolizumab, so immunotherapy as well, but that's not in there. So pre-op systemic therapy, mastectomy, radiation, and then based on what was found in pathology, they would continue their immune therapy to complete 1 year, and they would potentially have adjuvant oral chemo as well. Um, okay, so I haven't talked about uh, genetic testing yet. The patient we just saw, if they did have a breast cancer gene, sometimes would be offered an additional oral drug um, called olaparib if they're BRCA positive. So who do we want to do genetic testing on? So any new cancer patient, people now have pretty small families, so family history is only somewhat important. And because we now have a drug we can give adjuvantly, then we really want to know not only for the patient's family, but for this patient, whether or not they carry certain genes. And also, it helps determine what surgical therapy they may choose to have. We want to test all metastatic cancer patients, again, because we have drugs available, and anybody who was adopted and has unknown family history. Um, the most common mutations are the BRCA1 and 2 genes, um, the PALB2 gene, CHEK2 mutations, and ATM mutations. So, one thing to know is survival from the malignancy the patient currently has is not worse if you have a genetic mutation. So it does not change, it doesn't mean your cancer is going to have a poorer outcome. They do have an increased risk of a second breast cancer. Um, there has, in some cases, bilateral mastectomy is chosen by the patient. However, you can choose by breast conservation, and then you would undergo high risk screening. For example, mammography uh, once a year, an MRI once a year, staggered every 6 months. So let's say mammos every October and MRIs every April. There was a study presented 2 years ago that said, hey, patients do have a better survival if they have bilateral mastectomies, but that study did not include MRI screening, so we really do not know how to act upon it. And patients make the decision of would they rather continue to have ongoing imaging or would they prefer to preserve their breast tissue? And that's very much in the realm of shared decision making. Some different genes are associated with other kinds of cancers as well. Specifically, ovarian cancer is associated with the BRCA mutations. Okay, next topic, fertility. We've got a 32-year-old who's evaluated for a new diagnosis of estrogen receptor positive breast cancer. We're planning surgery, chemotherapy, so they must have had a high oncotype score. Um, Radiation, and 5 years of endocrine therapy. She wants to have kids. She's otherwise healthy. What is the best way to help the patient in the future have children? Yep, D is embryo or oocyte cryopreservation. Um, so you cannot try to conceive during endocrine therapy. Our drugs are teratogenic. You can do it after, absolutely, and many patients do. But you're starting with a 32-year-old, they're then 37, depending. And the worry is their fertility rates will be lower because they have had the chemotherapy. So some people do retain ovarian function, but some don't. So that's the hard part here. Depo-leuprolide does, if you give it during the chemotherapy and that shuts down the ovaries, that will improve the odds that a patient will still have ovarian function after the chemotherapy, but is not as reliable. So for patients who cannot afford embryo and oocyte cryopreservation, or don't want to do that, we will give the depo-leuprolide during their chemotherapy. But the most likely to result in subsequent pregnancy is the cryopreservation of embryos or oocytes. And embryos are better than oocytes, but they're better. The now egg cryopreservation has improved compared to what it used to be. Okay, next question. Another pregnancy question. 37-year-old is now 6 years out. She had stage 2 triple positive, ERP or HER2 positive breast cancer. She was treated with breast conservation, so lumpectomy, sentinel node biopsy, radiation. She had the combination of chemotherapy with the anti-HER2 antibodies, and then had 5 years of tamoxifen. And now they want to have a child. So the concern is, what is the increased risk um, to the patient or the future child because of this pregnancy? Okay, so the answer here is there is no increased risk of congenital malformations or breast cancer recurrence, which is awesome for these families. Um, it is an estrogen positive breast cancer. And so one could wonder if that's an issue, but happily we have now reasonable data, women who were tracked, and it's found to not increase their breast cancer recurrence rate or their breast cancer mortality. And we do know that women who actually have more pregnancies to term have less incidence of breast cancer. And that's as primary prevention, if you will. And it is safe for these women to get pregnant and have children, which is fantastic for them. Okay, so I threw in a slide on GLP-1s. It's very interesting emerging data. So observational research shows 30% reduction in breast cancer if you have overweight women who take GLP-1s. And we talked earlier about fat tissue being a source of estrogen. And it seems that women who have breast cancer and go on the GLP-1s have decreased odds of developing metastatic disease. This is really new data. And additional analyses show perhaps up to 60% mortality reduction. But this is really just came out at our meeting in June and is really new. It has some sense to it, but breast cancer doctors and us saying, should we be prescribing this for everybody? Like, but we're not there yet. But it's a really interesting question. And it also just points out how important it is not to have our patients gain weight, and a lot of them do on our endocrine therapy drugs, and how serious we have to now take that. Okay, last couple slides are on screening. So all kinds of guidelines from different agencies, generally starting age 40, typically ending age 74, or based on life expectancy with shared decision making with your patients. And the recommendations vary from every year or every other year in the United States. Um, and sometimes I'll ask a high risk screening question. Who should have that? So that would be patients at high risk, and there's usually calculators that help you determine this. What we hope to do is embedded in the mammography reports to make it easier for primary care is to ask all these the ideal state would be all these questions would be asked at the time of mammography. And so when the doctor receives the report, and it's a question whether you want the patients or not, but to identify, okay, based on this data, your patient has this, whatever your lifetime risk is, so you can be informed as to who to offer primary prevention to. So in general, the people we include in high risk are people who have high risk based on these calculators. People who have BRCA mutations, they start MRI age 25, mammography age 30. There's a question about what if they're first degree relatives of BRCA carriers and they haven't been tested. And the other group is people who had chest radiation, typically for Hodgkin's, age 10 to 30. They're at higher risk for later breast cancer, and they should have high risk screening. And that's what I got. People have other questions. Um, Let me know.